Severe mitral stenosis. Definition: mitral stenosis is characterized by obstruction to left ventricular inflow at the level of mitral valve due to structural abnormality of the mitral valve apparatus. The most common cause of mitral stenosis is rheumatic fever. The association of atrial septal defect with rheumatic mitral stenosis is called Lutembacher syndrome.
Mitral stenosis is a valvular heart disease caused by the narrowing of the opening of the mitral valve. This impedes the flow of blood to the left ventricle during diastole. Auscultation of an individual with mitral stenosis reveals an opening snap after the S2 heart sound. After the opening snap, there is a late diastolic murmur that has a rumbling, low-pitched quality. The murmur is typically enhanced by expiration due to an increase in venous return from pulmonary veins to the left heart. Almost all cases of mitral stenosis are due to heart disease, secondary to recurrent attacks of rheumatic fever. As the stenosis worsens, there is an increase in left atrial pressure that can cause dilation.
Applications in medicine. A number of conditions can simulate the physiology of mitral stenosis: severe non-rheumatic mitral annular calcification, infective endocarditis with large vegetation, left atrial myxoma, valvular thrombus, and cor triatrium. Indeed, a study by Iwataki et al. Indicate that in patients with degenerative aortic stenosis, calcific extension to the mitral valve causing mitral annular leaflet calcification can result in non-rheumatic mitral stenosis. Using real-time three-dimensional 3D transesophageal echocardiography in 100-watt patients with degenerative aortic stenosis and 26 control subjects, the investigators found an average decrease of 45% in the effective mitral annular area of the patients with degenerative aortic stenosis, as well as a significant reduction in the maximal anterior and posterior leaflet opening angle. Consequently, a significant decrease in the mitral valve area in this patient was found with an area of less than 1.5 centimeters to detect in 24 of them.
Now, supposing you have a narrowed mitral valve, so-called mitral stenosis, and that valve is narrowed, and if that is the case, then the leaflets will be wide open. And so what you'll hear is lub, dup, that's the first heart sound, and if the leaflets are wide open, then as the pressure rises in the ventricle, the leaflets have a long way to go, and therefore you hear a very loud first heart sound. So S1 is going to be loud, lub, and then you hear a normal dup as that valve closes, and then as the ventricle opens up, diastole starts, and the valve will snap open, so you hear a soft, barely audible opening snap. And then there's a very quiet murmur, because the pressure here is low, and so there's not much sound as the blood comes through the narrowed valve. But it is narrowed, and therefore there is a bit of a murmur. So you hear lub, dup, and then a snap, and then a very quiet mid-diastolic murmur that carries on, and it would get to the end, and just before systole, the atrium here will contract and push the last bit of blood through that narrowed valve, and so the murmur gets a bit louder, and that's called pre-systolic accentuation. And therefore, you hear a lub dup, then a quiet beginning of diastole, then opening snap, and then a very soft rumbling murmur that gets a bit louder at the end of diastole before the next very loud S1. The key really is that when you first listen, you hear a very loud S1 because of the long distance the mitral valve has got to go to close, and that should give you a clue to listen very carefully for the very quiet mid-diastolic murmur with pre-systolic accentuation. Of course, the pre-systolic accentuation will not happen if the atrium is not contracting, for example, in atrial fibrillation.
Pros and cons. The normal mitral valve orifice area is approximately 4-6 cm. As the orifice size decreases, the pressure gradient across the mitral valve increases to maintaining adequate flow. Patients will not experience valve-related symptoms until the valve area is 2 to 2.5 centimeters or less, at which point moderate exercise or tachycardia may result in exertional dyspnea from the increased transmission gradient and left atrial pressure. Severe mitral stenosis occurs with a valve area of less than 1 cm valve as the valve progressively narrows the resting diastolic mitral valve gradient and hence left atrial pressure increases. This leads to transudation of fluid into the lung interstitium and dyspnea addressed up with minimal exertion. Hemoptysis may occur if the bronchial veins rupture and left atrial dilatation increases the risk for atrial fibrillation and subsequent thromboembolisms.
At least in our country, we don't see rheumatic heart disease and mitral stenosis very frequently. Why? Because the antibiotics and penicillin have kind of eradicated rheumatic fever. Still, it's a problem in third world countries and many other countries. And it is also interesting from a historical point of view, because mitral stenosis was probably one of the first diagnoses which we were able to make with echocardiography. What are the hemodynamics behind mitral stenosis? Well, the problem is that we have obstruction to inflow to the left ventricle, and thereby we have a gradient between the left atrium and the left ventricle. This means that we have an elevated pressure in the left atrium, which translates to the pulmonary circulation, to the pulmonary capillaries, which leads to pulmonary congestion and in worst case even to pulmonary edema. And finally, we also have the development of pulmonary hypertension. What we also see is a reactive pulmonary component to pulmonary hypertension. For example, if you operate these patients for mitral stenosis, you will not infrequently still have residual pulmonary hypertension. The problems of the right heart that we see include tricuspid regurgitation and eventually even right heart failure. Because patients with mitral stenosis, as you will see, often have large atria, and because the pressure in the left atrium is usually increased, we not infrequently also see atrial fibrillation. So, patients with mitral stenosis can develop a number of different problems, which range from dyspnea all the way to pulmonary congestion and pulmonary edema, to arrhythmias, in particular, as already mentioned, atrial fibrillation, and thromboembolism, because we often see slow flow phenomena in the left atrium. So, this was some background information on mitral stenosis, in particular the hemodynamics, which will be very important when we look at the severity of mitral stenosis. But we haven't seen many image clips yet. It's time that we look at the echocardiogram and see how we can make the diagnosis and what we find in patients with mitral stenosis.
Issues applied in Ecuador. The prevalence of rheumatic disease is higher in developing nations than in the United States. In India, for example, the prevalence is approximately 100 and 150 cases per 1,000,000. And in Africa, the prevalence is 30 cases per 100,000. However, rheumatic fever has been decreasing in industrialized countries.
To the fullest, going out to eat, spending time with family, and taking vacations. But in her 80s, that all changed.
At the time when I met her, she was severely symptomatic. She had shortness of breath walking from one room to the other in her house. She could hardly make her own meals, and she was almost housebound. If she went out of the house, she had to use a wheelchair to get around. She's really limited.
Dr. George Hansel at Beaumont Hospital says a valve in Marion's heart was leaking.
When the mitral valve leaks, the blood flows back to the left atrium and subsequently into the lungs. And that can lead to a lot of problems such as shortness of breath and low energy and fatigue.
The condition is called mitral regurgitation. Eventually, it landed Marion in the ER with congestive heart failure. Doctors ruled out open heart surgery because of her age.
Since a lot of people just aren't good candidates for surgery, we've always been looking for new ways of trying to treat that. And one of the exciting ways is the mitral clip. This is a new technology that's actually based on a way of repairing the valve surgically.
In 2010, Marion came to Beaumont for a minimally invasive procedure, the Mitral Clip clinical trial, the only site in Michigan where it was being tested.
What can be done is, instead of doing open heart surgery, we can actually do a cardiac catheterization. We can insert the tube into the femoral vein, advance that into the heart, and position it at the mitral valve. What we can do then is clip the two leaflets of the mitral valve together at the area in the zone where the valve's leaking and not joining correctly. So we can really bring those leaflets together, help them approximate and join more normally, and therefore reduce the leakiness.
And it worked. 3 years later, at age 90, Marion still credits Beaumont doctors for giving her life back.
Beaumont was the only site in Michigan to participate in the clinical trials that have led to approval of this device by the FDA. And Beaumont will be the first site in Michigan to have this technology available to treat sick people with mitral regurgitation. After we did the mitral clip, she's had a dramatic improvement in her symptoms. At this point, she's able to get out. She goes visiting friends.
Conclusion. Stenosis of the mitral valve typically occurs decades after the episode of acute rheumatic carditis. Acute insults leads to formation of multiple inflammatory foci in the endocardium and myocardium. Small vegetation along the border of the valves may also be observed. With time, the valve apparatus become thickened, calcified, and contract, and commissural dilation occurs, ultimately resulting in a stenosis.
We are looking towards an animation of mitral stenosis. Now we can have a complete view. This is left heart, the left atrium, left ventricle, placed mitral valve in between. This is outflow of left ventricle, that from the aortic valves. Alright, this is right heart, right atrium, right ventricle, tricuspid valve, pulmonary valves heading towards the pulmonary trunk. Now in mitral stenosis, the most common cause is rheumatic fever after the streptococcal infection, throat infection, and then affects the mitral stenosis valve. Now in mitral stenosis, actually the narrowing of valve occurs, due to which it gives rise to the left ventricle inflow tract abnormalities. Again, when narrowing of the valve would occur, obviously intuitively we can have the narrowing of the valve leading to the left ventricular inflow tract abnormalities. That simple as that. So there would be more chances of pooling of blood in the left atrium, and now you may see the left atrium is stretching more. It would lead to the left atrial hypertrophy, which would be seen as then cardiac salute as the straightening of left heart border. Now also it would give indirect back pressure to the pulmonary veins and then to the pulmonary vasculature, which could lead to the pulmonary hypertension, or sometimes acute insults may lead to the interstitial edema, which is an emergency. All right. Now, so obviously the cardiac output would not be maintained, and later on, when the left ventricular hypertrophy may occur due to the progressive contraction, so that obviously the feedback mechanism, and also it may lead to the other finally the heart failure. That is a later consequences, but we are looking at the most basic part, that how it takes place. Now you may compare the abnormal valve with the normal valve, how this is opening. So you may have the 3D view. the valve is opening completely. It has three cusps, tricuspid, and mitral valve has only two cusps. Now you may see the how small meagerly it is opening and how it is well it is opening. Just compare it, and you can you yourself can deduce that what would be the consequences. So this is the advantage of seeing the animation and correlating with the clinical presentation. So this was the